VASS is a novel solution for limb and lower limb arterial recanalization using the antegrade ipsilateral femoral approach. Techniques currently adopted in intervention procedures in body apparatuses or in the vascular systems, for instance laparoscopic surgery or catheter angiography, are respectively based on Trocher or Seldinger techniques. Because of the progressively increasing indications in arterial territory, intervention techniques are frequently facing limitations due to the presence of massive calcifications in the vessel to recanalize. For the same reasons, subintimal recanalization, usually suggested in long lesions, may lead to poor results due to the exceeding difficulties in spontaneous wire re-entry in the reconstituted vessel, particularly in below-the-knee arteries, even if commercially available re-entry devices are used. Furthermore, in below-the-knee territory, an undue advancement of the subintimal wire across the plantar arch almost invariably leads to diffuse dissection. This may cause the exclusion or closure of the branches arising from this segment and exposes the patient to the risk of limb loss. The VASS system here described is based on a new .018 or .014 austenitic stainless steel stylet, which can be virtually inserted in any available 4F braided angle tip selective catheter. Moreover, both stylet sizes may be inserted in most over-the-wire .018 or .014 tapered peripheral balloons. These characteristics are now shown in the following animation. In this innovative procedure, focus is placed on safety and improvement of the visibility of the stylet's components. Particularly during fluoroscopy and filming, alternate three-dimensional orthogonal views are strictly required. This is largely facilitated by the ability to easily turn the fluoroscopy arch around the limb or lower limb. In brief, this new technique and device, expressly designed for the ipsilateral antegrade femoral approach, leads to a vast procedure simplification, higher success rate in crossing calcified lesions, and an easier re-entry maneuver in case the subintimal technique is adopted. Therefore, VASS provides a simplified approach to otherwise challenging endovascular scenarios. A stylet can be defined as a solid austenitic cylindric stainless steel body, uniformly tapered around the distal 2 to 3 cm, ending with an angled tapered tip. In addition, the piercing properties of the stylet are greatly enhanced by its elliptic egg-shaped tip surface. Therefore, this instrument holds greater piercing and crossing capabilities than any other device ever used inside the vascular bed. The specific angulation of the stylet's piercing surface is designed to prevent damage to the catheter lumen while advancing. In addition, the tapered distal 2 to 3 cm can flex while exiting the catheter, which, combined with its strong torqueability, allows the stylet to be directed towards any point in the 3D space independently from the specific catheter orientation. The effective operational range of the system, using a 45-degree angled catheter, can vary from 22 to 17 degrees. Further stylet advancement makes the reduced working angle suboptimal. When using a 90 degrees angled catheter, the effective operational range can vary from 35 to 20 degrees. Even in this case, further advancement of the stylet leads to a suboptimal working angle. Arterial recanalization using VASS may be performed by the intraluminal or subintimal technique. VASS's characteristics make the procedure easier thanks to its superior crossability and one-to-one steerability, especially in heavily calcified arteries. Once the stylet reaches the reconstituted lumen, a 3 mm diameter peripheral balloon, tapered at point 018, is advanced over the stylet to reach the distal lumen. Now, the stylet is removed and replaced by a point 014 wire to reach the distal circulation. Then, the balloon is inflated along the path to achieve a small lumen. The procedure is then completed with stenting as usual. Subintimal recanalization using VASS is performed as shown. The combination of an angled catheter and a point 035 straight wire is advanced, as usual, inside the occlusion for a few millimeters. The straight wire is then replaced with a tight J hydrophilic polymeric point 035 guide wire, which is advanced in the depth of the subintimal space in a loop-shaped fashion, followed step by step by the angled catheter. The wire loop advancement using angiographic control is then stopped at the level of the proximal reconstituted vessel. The J wire is removed and the stylet is inserted in order to pierce the calcified occlusion to reach the top of the reperfused artery. Differently from the currently available re-entry devices, VASS does not require to exceed the level of the proximal reconstituted artery, so avoiding dissecting it in an otherwise healthy segment. Using the subintimal recanalization technique, it is not infrequent for currently available re-entry devices to be very eccentric with respect to the lumen to re-enter, causing a very difficult or impossible re-entry. Due to the combined steerable characteristics of both VASS components, re-entry is achievable even in such demanding conditions.